There is a vitamin that approximately 1 billion people worldwide are deficient in right now. Not borderline low, genuinely deficient. And unlike most nutritional shortfalls, this one does not primarily cause fatigue or hair loss or the kind of vague symptoms that might prompt a concerned patient to ask for a blood test. Instead, it quietly disables a biological system that regulates immune function, cardiovascular health, bone density, muscle strength, hormonal balance, and the body's ability to suppress abnormal cell growth. It operates more like a hormone than a vitamin, which is exactly what it is, physiologically speaking, and its deficiency has been associated in major prospective studies with elevated rates of cardiovascular disease, autoimmune conditions, multiple cancer types, type 2 diabetes, depression, dementia, and all-cause mortality. The vitamin is vitamin D. And before you switch off because you have heard of it and perhaps even take a supplement, I need you to understand something critical. The standard blood test that GPs use to assess vitamin D status measures a threshold that was set to prevent rickets and osteomalacia, the severe deficiency diseases of childhood and institutional malnutrition. It was never calibrated against the full range of biological functions that vitamin D governs. What is considered sufficient by laboratory reference standards is, by the criteria of the broader research literature, insufficient for optimal immune regulation, cardiovascular protection, and cancer suppression. Hundreds of millions of people are being told their vitamin D is fine, while carrying a level that the research suggests is meaningfully suboptimal for their long-term health. For decades, vitamin D was understood almost exclusively in terms of calcium metabolism and bone health. Eat enough calcium, get some sunlight, and your bones will be fine. That was the full story as medicine understood it through most of the 20th century. What the past 20 years of research has revealed is that nearly every tissue and organ in the human body carries receptors for vitamin D, receptors that, when activated, regulate hundreds of genes involved in inflammation, immune response, insulin sensitivity, cell division, and vascular function. Vitamin D is not a bone mineral assistant. It is a master regulatory hormone that most people in the modern world are chronically undersupplied with. In this video, I am going to explain what vitamin D actually does in the body, why the standard threshold is dangerously low, which populations are most at risk, and what the consequences of chronic insufficiency look like across multiple organ systems, and what the evidence says about correcting it effectively. By the end, I will give you the specific blood level to aim for, one that differs significantly from what your laboratory reports as the lower limit of normal and the supplementation approach the research supports. Hi, I am Dr. Rachel. I am an emergency medicine physician with more than 11 years of frontline hospital experience. What becomes very clear when you work in emergency medicine is that the conditions filling hospital wards are rarely random. They follow patterns, metabolic, nutritional, and lifestyle patterns that were present years before the acute event. And vitamin D deficiency appears in those patterns more consistently than almost any other single nutritional variable. I have seen it in patients admitted with severe infections whose immune systems failed to mount an adequate response. I have seen it in patients with fragility fractures whose bone mineral density had been quietly eroding for years. I have seen it in the cardiovascular profiles of patients who presented with their first major cardiac event and whose entire blood work pointed toward a chronically underregulated inflammatory state. My goal with this channel is to give you the clinical context that connects those patterns so that you can identify and address vulnerabilities before they become the reason you are admitted, somewhere I have to treat you. That is genuinely what prevention means, not a poster in a waiting room, but a real understanding of what is happening in your body and what the evidence shows you can do about it. If you are watching this video, you are probably concerned about your long-term health. Perhaps you live in a country where sunlight is limited for large parts of the year. Perhaps you have been told your vitamin D is low and received little guidance beyond a generic supplement recommendation. Perhaps you have health conditions, recurrent infections, persistent fatigue, unexplained bone pain, low mood during winter months that have not been fully explained, and you are wondering whether nutrition plays a role. Whatever brought you here, I want to make you a promise. I promise to keep producing the most clearly explained, evidence-grounded content I can to help you understand your body well enough to make decisions that genuinely protect your long-term health. All I ask in return is that you give this channel a chance and hit the subscribe button below. If you reach the end of this video and feel you have not learned something genuinely new and useful, feel free to unsubscribe, no hard feelings at all. But if you give me your attention, I will give you everything I have learned from over a decade in clinical medicine. Please hit subscribe and help this channel reach more people who need this information. And let us continue. To understand why vitamin D deficiency has such far-reaching consequences, you first need to understand what vitamin D actually is at the biological level, because the name is misleading. The word vitamin implies something that must be obtained from food in small amounts to prevent a specific deficiency disease. Vitamin D does not fit that description. It is synthesized in the skin from cholesterol in response to UVB radiation from sunlight, converted in the liver to a circulating storage form called 25-hydroxyvitamin D, which is what blood tests measure, and then converted again in the kidneys and in tissues throughout the body to its active hormonal form called 1,25-dihydroxyvitamin D, or calcitriol. That active form then binds to vitamin D receptors found in virtually every cell type in the human body and directly regulates gene expression. This is the distinction that changes everything about how we should think about vitamin D sufficiency. A hormone that regulates gene expression in nearly every tissue does not simply prevent rickets when present and cause rickets when absent. It modulates biological function across an enormous range of systems, and its absence or insufficiency degrades those functions proportionally. The research literature has now identified more than 2,000 genes whose expression is directly regulated by the vitamin D receptor. Those genes are involved in immune modulation, inflammatory signaling, insulin secretion, cell cycle regulation, neurotransmitter synthesis, cardiac muscle function, and vascular tone. Vitamin D is not a micronutrient that plugs a single metabolic gap. It is a regulatory signal that the entire body uses to calibrate its function. Here is where the clinical picture becomes particularly important to understand. The standard laboratory threshold for vitamin D sufficiency, typically set at 50 nanomole SLAL or 20 nanomole SLAL in the units used in the United States, was derived from studies of bone metabolism. Specifically, it represents the blood level above which parathyroid hormone is suppressed and calcium absorption is adequate to prevent rickets and osteomalacia. It was never determined by studying the vitamin D levels associated with optimal immune function, cardiovascular protection, cancer risk reduction, or cognitive health. Those are different biological endpoints, and the research shows they require meaningfully higher vitamin D levels to support. Research published in Nutrients and in the American Journal of Clinical Nutrition has consistently demonstrated that the non-skeletal functions of vitamin D, immune regulation, inflammatory modulation, insulin sensitivity, cancer suppression, are optimally supported at blood levels of 75 to 125 nanomole SLAL or 30 to 50 ngar. A patient with a vitamin D level of 55 nanomole SLAL will be told their result is normal. They will receive no further advice, yet that level sits well below the range associated with optimal immune and cardiovascular function. Think of it like maintaining your car's oil level at the minimum required to prevent the engine seizing, technically adequate to avoid catastrophic failure, but well below the level at which the engine runs cleanly and efficiently for the long term. This distinction between sufficient to prevent deficiency disease and optimal for systemic health is one of the most consequential gaps in routine clinical guidance, because it means that a substantial proportion of people receiving reassurance about their vitamin D status are, by the criteria of the broader research literature, chronically insufficient in a compound that regulates their immune, cardiovascular, and metabolic function. Vitamin D deficiency is not uniformly distributed. Several factors dramatically increase the risk of chronic insufficiency, and understanding them is clinically important, because many people carrying multiple risk factors are not being screened with appropriate frequency or appropriate thresholds. The first and most significant factor is latitude and season. UVB radiation, the specific wavelength of sunlight that triggers vitamin D synthesis in the skin, does not reach the Earth's surface at useful intensities at latitudes above approximately 35 degrees north or south during autumn and winter months. In practical terms, this means that anyone living in the United Kingdom, most of Europe, Canada, the northern United States, and similar latitudes cannot synthesize meaningful amounts of vitamin D from sunlight for approximately 5 to 6 months of the year, regardless of how much time they spend outdoors. For this population, dietary and supplemental sources must compensate entirely during winter, and most do not. The second factor is skin pigmentation. Melanin, the pigment that gives darker skin its color, acts as a natural UVB filter, reducing vitamin D synthesis in the skin. Individuals with darker skin require significantly more sun exposure to synthesize the same amount of vitamin D as individuals with lighter skin. In high-latitude countries with limited sunlight, this creates a compounding vulnerability. People of South Asian, African, and Middle Eastern heritage living at northern latitudes face both the seasonal UVB deficit and a reduced synthesis rate. Research published in the British Medical Journal found that vitamin D deficiency rates among South Asian adults living in the United Kingdom were substantially higher than in the white British population, with the majority carrying levels that met even the conservative laboratory definition of deficiency. The third factor is age. The skin's capacity to synthesize vitamin D from sunlight declines significantly with age, by approximately 75% between the ages of 20 and 70, according to research published in the Journal of Clinical Endocrinology and Metabolism. The kidney's efficiency at converting the storage form to the active hormonal form also declines with age. This means that an older adult spending the same amount of time in the same sunlight as a younger adult will produce a fraction of the vitamin D. Given that the 45 to 75 age group is also the demographic with the greatest risk of the conditions vitamin D helps regulate: cardiovascular disease, cancer, immune decline, cognitive deterioration, and musculoskeletal frailty, this age-related reduction in synthesis capacity is a significant and substantially under-addressed clinical problem. The fourth factor is body composition. Vitamin D is fat-soluble, meaning it is stored in adipose fat tissue. In individuals with high body fat, vitamin D is sequestered into fat cells and removed from the circulation. This creates a dilution effect. The same vitamin D production or intake in a person with high body fat results in a lower circulating blood level than in a leaner person. This is why obesity is an independent risk factor for vitamin D deficiency, and why supplementation doses may need to be higher in this population to achieve optimal circulating levels. With that understanding of the mechanism and the risk factors established, let me be specific about what chronic vitamin D insufficiency actually does across the organ systems it regulates. The immune system is the most immediately consequential domain. Vitamin D receptors are expressed on virtually every immune cell: T cells, B cells, macrophages, and dendritic cells. In the presence of adequate vitamin D, these cells respond to pathogens in a calibrated and appropriate way, mounting a strong initial response, then resolving the inflammation once the threat is neutralized. In the absence of adequate vitamin D, two things happen simultaneously. First, the innate immune response, the first-line non-specific defense against pathogens, is weakened. The body produces fewer antimicrobial peptides, particularly cathelicidin and beta-defensin, which are the compounds that directly destroy bacteria and viruses at the cellular level. Research published in Science demonstrated that vitamin D is essential for the activation of T cells in response to infection, and that T cells in vitamin D deficient individuals fail to mount an effective response even when other immune parameters appear normal. The second immune consequence is equally important. The resolution of inflammation becomes impaired. Vitamin D actively suppresses the production of pro-inflammatory cytokines, the signaling molecules that drive immune activation, and promotes the production of anti-inflammatory regulators. When vitamin D is insufficient, the immune system tends to remain in a state of low-grade inflammatory activation that does not fully resolve. This is the mechanism linking vitamin D deficiency to autoimmune conditions, where the immune system fails to distinguish self from non-self and attacks the body's own tissues. Research published in the Journal of Autoimmunity found that vitamin D deficiency was associated with elevated rates of multiple sclerosis, rheumatoid arthritis, and type 1 diabetes across geographically diverse populations, and that latitude, as a proxy for sunlight exposure and vitamin D synthesis, was one of the strongest predictors of autoimmune disease prevalence globally. In the cardiovascular system, vitamin D regulates the renin-angiotensin system, the hormonal pathway that controls blood pressure. In the absence of adequate vitamin D, renin production increases, which drives angiotensin II production, which constricts blood vessels and elevates blood pressure. Vitamin D also directly modulates cardiac muscle function and endothelial health. Research published in Circulation found that individuals with vitamin D levels below 50 nmol had significantly elevated rates of heart failure, coronary artery disease, and sudden cardiac death compared to those with levels above 75 nmol independent of traditional cardiovascular risk factors. In the context of cancer, the evidence is both substantial and under-discussed. Vitamin D regulates cell cycle progression, promotes apoptosis, the programmed death of abnormal cells, and inhibits the development of new blood vessels that feed tumor growth, a process called angiogenesis. A large-scale meta-analysis published in the British Medical Journal, pooling data from multiple randomized controlled trials, found that vitamin D supplementation was associated with a statistically significant reduction in cancer mortality, meaning people with higher vitamin D levels who developed cancer were less likely to die from it. The effect was most pronounced for colorectal cancer, where the association between low vitamin D and elevated risk has been replicated across dozens of independent studies. And just really quickly, if you are finding this genuinely useful so far, please consider hitting the subscribe button below. It genuinely helps these videos reach more people who need this information. Anyway, let us continue. So let me name this directly, because I want the practical implication to land clearly. The reason vitamin D deficiency is so consistently missed, not in its severe form, which rickets and osteomalacia make visible, but in the chronic, functionally significant insufficiency that impairs immune, cardiovascular, and metabolic function, is a combination of a calibration error in the reference range, a testing frequency that does not reflect seasonal variation, and a clinical culture that treats supplementation as a minor lifestyle intervention rather than as a genuine therapeutic correction. The calibration error I described in the science section has a downstream effect that plays out millions of times a year in GP surgeries. A patient has their vitamin D tested, perhaps because they reported fatigue or bone aches, and receives a result of 52 nmol. The laboratory flags this as normal. The GP, whose threshold for concern sits at the laboratory's lower limit, reassures the patient and moves on. The 52 nmol is below the range associated with optimal immune regulation. It is below the range associated with meaningful cancer risk reduction. It is below the range associated with robust cardiovascular protection. The patient was not incorrectly told they lacked deficiency disease. They were incorrectly told they were fine. The seasonal dimension compounds this systematically. In high-latitude countries, vitamin D levels in the general population peak in late summer, following months of sunlight exposure, and fall progressively through autumn and winter. Reaching their lowest point in February and March, the patient tested in September may have a level of 72 nmol adequate by both laboratory and research criteria. The same patient tested in February may have a level of 38 nmol insufficient by research criteria and borderline by laboratory criteria. If testing is done at the right time of year, the problem is invisible, and most testing is not timed with this seasonal variability in mind. The at-risk populations I described, older adults, people with darker skin living at high latitudes, individuals with higher body fat, those who spend most of their time indoors, are precisely the populations whose GP interactions are most likely to be focused on managing existing conditions rather than investigating nutritional insufficiency. A 68-year-old patient with hypertension, borderline blood sugar, and moderate obesity arriving for a routine appointment will spend most of that appointment on medication review. Vitamin D, unless the patient raises it, is unlikely to be tested, and yet this patient sits in the intersection of every major risk factor for severe vitamin D insufficiency, age, body composition, and potentially indoor lifestyle, and simultaneously sits in the intersection of every condition that vitamin D insufficiency accelerates. This is not a failure of individual physicians, most of whom are working within appointment structures and guideline frameworks that do not prioritize this investigation. It is a failure of guidelines that were built around a bone-focused model of vitamin D function and have not been updated to reflect the breadth of evidence that has accumulated over the past 2 decades. The people who followed their doctor's reassurance acted entirely reasonably. The reassurance was built on an incomplete framework. So what is the practical path forward? I want to be clear that vitamin D supplementation, while generally safe, does carry a risk of toxicity at very high doses, specifically through the accumulation of calcium in the blood, a condition called hypercalcemia. This risk is real but rare, and it is almost entirely avoidable with appropriate testing and reasonable supplementation doses. The goal of everything I am about to describe is informed, monitored supplementation, not self-prescribed megadosing. If you have existing kidney disease, sarcoidosis, or any condition affecting calcium metabolism, please discuss vitamin D supplementation explicitly with your doctor before proceeding. The test to request is a 25-hydroxyvitamin D level, written as 25-OHD. This is the circulating storage form of vitamin D and the standard clinical measure of vitamin D status. When you receive your result, the threshold to bear in mind is not the laboratory's lower limit of normal, typically 50 nmol/L or 20 nmol. The research-supported optimal range for non-skeletal health outcomes is 75 to 125 nmol/L or 30 to 50 nmol/L in US units. A result between 50 and 75 nmol/L should be understood as insufficient for optimal systemic function, even if it is not flagged as deficient by the laboratory. A result below 50 nmol/L represents genuine deficiency by any reasonable clinical standard. And a result below 30 nmol/L, which is more common than most people realize, particularly in high-latitude winters, represents the severe deficiency range in which multiple biological systems are meaningfully compromised. Given the significant seasonal swing in vitamin D levels at high latitudes, the most clinically informative time to test is in late winter, February or March, when levels are at their seasonal nadir. A result obtained in late summer, following months of sunlight exposure, may appear adequate while concealing a trajectory that will fall into insufficiency through the autumn and winter months. Testing in late winter gives you the most accurate picture of your lowest annual level, the level at which your immune system, cardiovascular system, and other vitamin D-dependent functions are operating for several months each year. This is the number that most accurately reflects your true chronic exposure. If your level is below 75 nmol/L, supplementation is warranted. The form of vitamin D that matters here is D3-cholecalciferol, which is the form synthesized naturally in the skin and the form that research has consistently shown to be more effective raising and maintaining circulating 25-OAD levels than vitamin D2, the plant-derived form used in some fortified foods. For adults with a confirmed insufficiency levels between 50 and 75 nmol/L, a daily dose of 1000 to 2000 IU of vitamin D3 is a reasonable and well-tolerated starting point, consistent with the guidance of multiple endocrinology societies. For confirmed deficiency below 50 nmol/L, doses of 2000 to 4000 IU daily are commonly recommended under medical guidance, with a follow-up test at 3 months to confirm the level has reached the target range. Vitamin D3 is most effectively absorbed when taken with a meal containing some dietary fat, given its fat-soluble nature. This is a nuance that most general vitamin D guidance omits, and it is worth understanding. Vitamin D promotes calcium absorption from the gut and increases circulating calcium levels. Vitamin K2, a distinct compound from the vitamin K1 found in green vegetables, directs that calcium into bone and teeth where it belongs and away from soft tissues such as artery walls, where calcium deposition contributes to arterial stiffness and cardiovascular disease. Research published in the Journal of Nutritional Biochemistry found that combined vitamin D and K2 supplementation was more effective at improving bone mineral density and reducing arterial calcification than vitamin D supplementation alone. Think of vitamin D as opening the gate for calcium to enter the body, and vitamin K2 as the traffic controller that directs it to the right destination. For individuals taking vitamin D at doses of 2000 IU or above, co-supplementation with 100 to 200 micrograms of vitamin K2 in the MK7 form is a reasonable and increasingly evidence-supported practice. Supplementation is the primary strategy for high-latitude residents through autumn and winter, but sunlight remains the most physiologically natural and effective source of vitamin D during the warmer months, and optimizing its contribution during those months reduces the deficit that supplements must correct. The key practical points are these. Sunlight exposure needs to involve skin not filtered through glass, which blocks UVB and not blocked by high SPF sunscreen during the entirety of the exposure period. Midday sun, when UVB intensity is highest, is the most effective period. For lighter-skinned individuals at mid-latitudes, 15 to 20 minutes of direct midday sun on the arms and legs during summer months is sufficient to produce significant vitamin D. Darker-skinned individuals require longer exposures to achieve the same synthesis. This is not a recommendation to avoid sun protection. extended unprotected exposure carries real skin cancer risk, but to understand that the very brief periods of unprotected midday exposure that produce meaningful vitamin D synthesis are not the same risk category as hours of unprotected recreational sun exposure. And as I always note, please do not alter any existing medical management or begin supplementation at higher doses without discussing it with your doctor if you have kidney disease, a history of kidney stones, or any condition affecting calcium regulation. For most otherwise healthy adults, the supplementation doses I have described carry an excellent safety profile and are consistent with guidance from major endocrinology and nutrition bodies, but individual circumstances always warrant individual clinical judgment.